Hi, welcome back. Now we're moving on to breathing. As a recap, we talked about the red airway. That's a patient who's unconscious and not breathing. You're going to determine if the patient has a reversible cause, as we discussed, by repositioning the head, potentially putting a nasal airway, bagging the patient looking for obstruction, checking the gag reflex, considering the utility of Narcan, and checking for a pulse. We discussed the yellow airway, where the airway is threatened. This is typically by some form of oral or neck pathology. It's very important in these cases to determine how fast the disease is progressing, whether it's rapid or slow, and whether it's potentially reversible. This is how you will decide whether you'll take action. We also discussed the green airway. When a patient introduces themselves to you in a normal voice, that's a green airway and you can move on to breathing. A red light in the case of breathing is exactly the same as a red light in the case of airway. It's typically an unconscious patient who's not breathing at all, and you'll go through the same things you do for the airway. A yellow airway is often someone in severe respiratory distress. The patient will have some component of oxygenation or ventilation failure. When a patient has oxygenation failure, they'll usually come in maximizing the efficiency of their breathing. They tripod. They're in a sniffing position. Their back is straight, their hands are on their knees, and they're extending the back as much as possible. The chin is extended and the airways open. The abdominal and chest wall are not impeding respirations because the weight of them is leaning forward. They have maximal excursion of their diaphragm, and they're doing absolutely everything to get air in. They're typically tachypnic and tachycardic and often diaphoretic. They're focused on breathing and nothing else. In the worst cases, the patients won't even look at you when you speak to them. That's actually a good sign to watch for follow-up, because as the patients improve, they start to notice what's going around them, watching the nurses get the IV, engaging with people with their eyes, looking at you, checking things out, looking at the monitor. When a patient comes in extremis and they're not focused on anything, when they start to look around at the things going on, that's a very good sign that they're improving. These patients will also resist any attempt to lay them down. They're maximizing their oxygenation, and they don't want to change that. But this maximization of effort cannot go on forever. Without intervention, they'll get chest wall muscular fatigue, diaphragmatic fatigue, respiratory failure, lactic acidosis, and cardiac arrest. When a patient comes in respiratory distress, if left untreated, they will usually progress to ventilatory failure. They'll come in working very hard to breathe. Doctor, please fix me. I came here for help. If they're not fixed quickly, they'll start to tire out. They'll start to lay back in the bed and cooperate much better with what the nurses are asking them to do. This is not always a good sign. If the patient can no longer fight and no longer sit up and maximize their breathing, that means they're probably on their way to ventilatory failure, unless they're telling you that they're feeling much better. If left unchecked, they assume the C position. This is tragic. When the neck is bent and the back is positioned in the way of a C and they're collapsing in the bed. This is the last thing you see before they actually arrest. At this point, they're begging you, please somebody, anybody notice and intubate me. Nobody should die in the hospital without an airway. In the case of the JABA, this progresses much faster. People with large necks, oral obstructions from adenoids and large tongues, large abdominal walls and large chest walls, once they cannot hold the position, the best respiratory position possible, they deteriorate very quickly, accumulate CO2 very quickly, and arrest much more quickly than someone with a different body habitus. Rule of thumb: no one in respiratory distress should be relaxed, and no one in respiratory distress should have a heart rate less than 100. These are signs of impending cardiopulmonary arrest. Respiratory failure is a Venn diagram of oxygenation failure, ventilatory failure, and cardiac arrest. So how do we approach the severe respiratory distress patient? Well, you ask the 3 magic questions, of course. The first question is, do I need to emergently intubate? The indications for this are failure to oxygenate, failure to ventilate, and failure to protect the airway. If you can't reverse any of these failures, this patient should be quickly intubated. This doesn't mean that if someone's hypoxic that you don't give them a trial of oxygen, or if their ventilation is difficult for them, that BiPAP might not be a reasonable intervention. In someone who can't protect their airway, who is opiate intoxicated, Narcan may reverse it. But if all the immediate efforts don't work, then the patient should be emergently intubated. So if you don't have an emergent indication to intubate, you ask yourself the next question, which is there a rapidly reversible cause? If not, you should quickly move on and intubate the patient. It is predictable that patients without a reversible cause will quickly deteriorate and likely arrest. There are not very many rapidly reversible causes. Hypoxemia is one cause that you can easily reverse by treatment with either oxygen supplementation, CPAP, or BiPAP. Bronchospasm can be treated with bronchodilators. Hypertensive pulmonary edema can be treated with oxygen, blood pressure control. Pneumothorax can be treated with a needle. Allergic reactions, typically in this case, will be treated with epinephrine and Benadryl, as well as steroids and H2 blockers. So if you do have a rapidly reversible cause, you're going to move on. If you don't have a rapidly reversible cause, such as if a patient is on BiPAP and has bilateral pneumonia and they're still in respiratory distress, they're not going to fly. They need to be intubated. If it's not a reversible cause, you're probably not going to avoid the intubation. So do it sooner rather than later. Don't wait for them to arrest. And if you're going to wait, make sure you monitor the VBGs very closely for deterioration. If they have a rapidly reversible cause, the next question you're going to ask yourself is, can he run? You can look at a person and just say, what is the likelihood that that person can run up 3 flights of stairs? Or what's the likelihood that they can run around the block? You quickly have an answer to that question just by looking at someone. You get a good idea. This information will help you to determine how much time you will allow for intervention. For instance, if you have a patient who is having a severe asthma attack and is in severe respiratory distress and is 25 years old and otherwise very healthy, looks strong, looks like he could run a marathon, you can keep trying to treat that patient a lot longer than you would in someone who has underlying severe cardiac disease, severely anemic, body habitus, BMI 45. These things might send you toward intubation faster than someone who's young and healthy, who can fight the fight until the medications kick in much better. The components of can he run are basically body habitus, underlying medical problems, including cardiac function, age, and severity of symptoms. Once you decide that the patient can run, you set time limits. You look at them and size them up and think, how long will I let this go before the patient will improve? Or when should I start to think about intubating this patient? And then you adjust based on the response to therapy. When you assess the response to therapy, you're going to be looking at the symptoms. What the patient says is going on is usually the best thing that you can look at. They know that it's feeling better before you see other manifestations of the improvement. The work of breathing is going to be very important. Saturation, VBG for the CO2, the lactic acid, and the pH, and frequent reassessments are very important. On to the green. If you have a patient who is breathing, when you're going through ABCs, is green, the patient will be speaking to you in full sentences, normal respiratory rate with good oxygen saturation. All right, thanks for coming back. See you next time.